Welcome everyone to the first webinar for Thursday of the Virtual SMA Conference. This is Jessica from Cure SMA's Family Support Department, and we thank you all for joining with us today. We would like to thank our national presenting sponsors for their generous support of the 2020 Virtual SMA Conference, Avexis, Biogen, and Genentech. And we recognize the support of our visionary sponsor, Ionis, platinum sponsor, Scholar Rock, and silver sponsors, Acredo and Permobile. We appreciate all the questions we received in advance of the webinar, and we'll try to answer as many of these as we can during the presentation. Please note that all lines will remain muted during the webinar other than for speakers. Now we would like to welcome our presenter, Renee Hill, a speech and language pathologist who will be presenting on oral placement therapy using muscle-based therapy with clients with the diagnosis of SMA. Renee?
Let me unmute myself. Thank you so much. I'm very excited to be here. I wish we were all together in person, but it's amazing that SMA has pulled together and been able to pull off this virtual webinar for the first time. So I'm very honored to be a part of it. I've got about 7-8 hours of information to squeeze into 45 minutes. So we're just going to go ahead and get started. And then at the end, if I have time, I'll tell you a little more about myself, and I'll promise I'll give you my contact information if you'd like it. So we'll go to the next slide. All right, so let me start out with my why. I have been a speech pathologist for about 21 years, and I started specializing pretty early in muscle-based therapy. And then my cousin had a daughter who was diagnosed with SMA, and I got to try out some of my skills with her. I hadn't heard about SMA before Madison was born and diagnosed, and so I have grown on this journey with her. Next slide. So let me start with just some basic principles and some things that to know about this particular type of therapy. It's a type of therapy that speech pathologists would specialize in. It's not something that we are trained in at school. So we'll talk a little more about finding therapists who do this a little bit later. But this type of therapy is beneficial for all ages. And I often get asked, how young do we work with clients of any diagnosis? And my answer is, as soon as they know that there's potential for a problem. A lot of times when we see babies who have a diagnosis, there may not be any issues at the moment, but we want to meet them, and we want to get them in our Rolodex and on our caseload so that we can follow them, because sometimes those issues start to present themselves later. And we can do a lot with kids when they're young, when we know there's a muscle-based problem, to help them maintain the skills that they have and not develop any bad habits. On the same side, we can work with adults very late in life, and we know we can do this because muscles can change at any age, especially in this new era of having medicines that are helping rebuild muscle. We can then work with those people on improving their function as well, almost like a physical therapist. When we start with most of our clients, we start with feeding. All of our motor movements early on develop from feeding, and it helps prepare the structures for movements for later speech. So there again, that's why we can start with our kids so young. We can start working and making sure that they are breastfeeding and bottle feeding, using good movement patterns, and that helps them get to that next step, and so on and so forth. Another principle to consider is early motor skills also assist in the development of the oral structures. So your jaw, believe it or not, your dentition is developing around how you use your mouth. Your palate is being shaped by some of these early motor skills, your lips and your tongue. So all of these movements that should be happening early on are helping us develop our entire face. And so again, the earlier we can look at these kids and make sure their tongue is in the right position at rest and they're using those muscles appropriately, we can help them with some of that. We can help with some of that bony structure as well. The philosophy of OPT therapy, and OPT stands for oral placement therapy, is inappropriate movement cannot support normal structure or clear speech. So in oral placement therapy, we're going back a step and looking at the functions of the muscles in the mouth to make sure that they are working to the best of their ability to support the goals that we typically have in speech pathology, which is clear speech and good feeding as well. All right, next slide. So why do we want to consider oral placement therapy in addition to traditional therapies? And when I talk about traditional therapies, this is what we're typically taught in school. In school, we're taught if a child or an adult we're working with is having trouble with speech, we work on speech sounds, we work on putting speech sounds together. If they're having trouble with feeding, we work on feeding. Oral placement therapy is an addition to that traditional therapy. So instead of just working on the sounds, we're going to go back a step and look at the muscle movements needed for those sounds. Because what we've learned over the years is that people who have muscle-based disorders, and SMA falls into that category, if we don't address the function of the muscle and the skill of the muscle and teach it to move appropriately, it's really hard to teach standard speech and standard feeding and swallowing. So we're going to add that oral placement therapy to our speech and feeding therapy. OPT uses the sensory system to make, and it left off the rest of the sentence. So what I'm assuming I meant there, oh, no, the dots, the dots came out wrong. So if you read this all as one sentence, OPT uses the sensory system to make the motor system work. One of the principles that we use in oral placement therapy is your sensory system and your motor system are connected. So what you feel helps your motor system move. And so a lot of kids and adults that we work with muscle-based issues, their sensory systems aren't exactly like a typical sensory system. They may not feel things the way you and I feel them. If you put a piece of food in your mouth, you can feel it and you automatically know where you need to move it in your mouth. If it's something smooth like pudding, you know if you place it in the middle of your mouth, you can just swallow it. But if it's something crunchy like a chip, you know to put that in your mouth and move it to your molars and chew it. So some of our young ones who maybe don't have that sensory organization, sometimes they have difficulty developing those movements. And then we have clients who have overactive sensory systems where when they put something in their mouth, it's not comfortable and it makes them gag and they can't figure out what to do with it. So we work on normalizing that sensory system, and we also use that concept of sensory to help the motor system work. And I'll give you an example in another slide in just a little bit and in a video. So it's like physical therapy for the mouth. So we're basically adding physical therapy to speech therapy. So working on those muscles first and then transferring it to speech or feeding as we're, whatever our goals are. Next slide. So we know that there are different types of SMA, and the impact it has on feeding and speech can be different based on those diagnoses. And now with the drug therapies, how well the drug therapy is working can also impact what we're seeing, even without some of this therapy we're recognizing. So we know that type 1 is more severe, and we see more problems or more difficulties with those clients. Their muscle tone and function is much less than, say, a type 3. So when we talk about our different types, we're looking at how much intervention we might need, and sometimes also what those expectations might be. And some of that is driven by what age they are, how long have they gone without a muscle-based therapy, and some of those things can be impacted more than others. So I just wanted to put this little slide in there so you can kind of think about where your child or you might fit into these categories and what you may be feeling as a response to that. So for example, type 3s, they might not have many feeding and speech deficits that we can really see, but often we see, especially as they get older, difficulty with pain in the jaw. They fatigue quickly, so towards the end of the day, they have maybe shorter breath, so their speech is less, is more difficult, and maybe their mouth muscles get difficult. And we can assist at any of those levels, and the therapy changes based on what's going on. Next slide. So one of the things I want to start with is oral rest posture, and this is a, I don't want to say it's a new area of speech pathology, but I think more and more speech pathologists are getting interested and starting to see the connection between how we hold our mouth at rest and how our face develops, and then eventually how that impacts feeding and speech. So what we want to see when we say a person has a good oral rest posture is a high relaxed jaw. So high means that your teeth are close together, your lips are relaxed and closed, and your tongue is elevated to the palate. So as you're sitting and listening, your mouth is probably still. You can kind of analyze and ask yourself, is that where my mouth is? This posture that we want to see from birth helps facilitate normal development of the oral structure. So how the jaw, the face, and the teeth are all going to come in. So if you're a person with SMA who's older and maybe has had some oral motor problems, you might recognize that your mouth isn't in that position. And as growth occurs and bony structure develops, sometimes that can impact later what you can do with your mouth. And then that often requires even more intervention. I'll also mention here that a lot of dentists are becoming more interested and thoughtful in oral rest posture. And part of that oral rest posture is also creating a good breathing pattern. So we should be breathing through our nose, not through our mouth. And there's lots of reasons why. But dentists are starting to recognize that when that mouth is open and all those teeth aren't coming in the way they're supposed to, and the palate is the wrong shape, that's affecting their jobs as well. Next slide. Okay, so when we think about a little bit when we think about abnormal rest postures, here's some different pictures to kind of show you some of those. So when there's muscle weakness and the muscles aren't exercised, or there could be airway issues. So we know with SMA, there's a lot of airway and breathing issues. And so sometimes our clients need to open their mouth because that's the only way and the best way that they can breathe. And that we just need to know that long-term mouth breathing can change the shape of the mouth. So if you look at that little, that second picture, with the little boy with the glasses, and his mouth is wider open. If you look inside his mouth and kind of look at his teeth, you can see that instead of it being flat like mine, it's kind of arched up. And so not only are his teeth coming in a little bit differently, but his palate is really high. So when we talk about your tongue needing to be up in your palate when your mouth is closed, that's helping your palate shape. And so this little guy probably from very early had breathing issues and needed to have that mouth open. So instead of his palate developing nice and round around his tongue, which would be right here, his tongue is way down here, so his palate has arched up. And so that can make some things problematic, not just breathing, but swallowing can be difficult for a person that has a high palate, and speech as well. So we want to make sure that as we're working with our clients with SMA, we're aware of this and doing as much as we can to help with the muscles to help them keep their mouth closed. Okay, next slide. So some of the things that we think about when we think about the effects of SMA on feeding and speech. So number one, adequate muscle movement, strength, and endurance must exist for standard function to develop. So in order for us to be able to speak clearly and swallow easily, those muscles should be performing or working at a certain level. And we also know that light exercise and continued use of these muscles can assist in prolonging skill that is there potentially, or now helping improve function with many of these clients that we work with. Okay, next slide. So when we think about oral placement therapy, I wanted to just share with you some of the goals that we're trying to meet with this type of therapy. So the first one is to increase the awareness of the mouth and normalize tactile sensitivity. So if you remember back to a few slides where we talked about the sensory system and the motor system being connected. Okay. Many children and adults with muscle-based deficits have poor oral awareness. They might not be able to feel the saliva, and so we have some people who don't swallow saliva and are drooling because they can't feel that saliva. Drooling can also be seen because the client has problems with swallowing itself. So it's not always just a sensory issue, but remember, sensory and motor are connected. So we're looking at both of those all the time. Some of our clients might not feel food in their mouth, and so therefore they're not chewing the way they're supposed to, or when food goes in their mouth, they're not swallowing unless they're told to swallow, things like that. And then our clients who do not get good oral experiences in normal ways through eating and swallowing, mouthing objects as infants, which is really an important step to sensory motor development, they often have imbalanced or abnormal sensory systems. So they can become more sensitive or have reduced sensation to typical things. So some of our clients with SMA who maybe are more affected and had more difficulty early on with breathing and holding their head up and those kinds of things, maybe not eating by mouth, they often didn't get those experiences the way they needed to. And so now, as they're a little bit older and maybe they can eat, and we start to put foods in their mouth, maybe they have a little bit of trouble with it because their sensory system doesn't know what to do with it. So we're working on that as part of our goals. Next slide. Okay, one of our second goal is to improve volitional movement of the mouth. So the jaw, lips, cheeks, and tongue for speech, oral rest, posture, and eating. So when we talk about OPT by itself, we're looking at exercises and activities to help facilitate movement. Even if they're not eating yet, maybe they're not even verbal, we can work on trying to improve some of that function through functional activities or mouthing activities, and then eventually possibly transition it to feeding if that's a goal, or speech if that's a goal. So the jaw, the lips, and the tongue should be able to move independently of one another, and we call this dissociation. So for example, I can open my mouth and put my jaw really low, and I can move my tongue without moving my jaw. And that's what we call dissociation. And a lot of times people who don't have dissociation, everything moves together. So if I wanted to move my tongue up and down, I might use my whole jaw. So we're trying to help them develop some of those movements that are needed. Next slide. So here's a little slide that just talks about dissociation, and I'm not going to have enough time to go through and teach this, but I want you just to be aware that if you look in the left column, muscle movements develop following a normal developmental pattern. Feeding skills are developing as those muscle movements come in, and then sounds, phonemes, develop as those muscles are coming in as well. So the first one on the list, being able to open your lips, is the easiest step for babies to do. And babies open their lips to do bottle drinking and breastfeeding. And the early sounds that we usually hear with babies when they're first learning sounds are mouth open sounds. And then it gets more and more, the movements become more refined and more specific and more difficult, although none of them are really difficult, but they develop in a pattern. So if you look at the sounds on the right, those sounds at the very bottom, the SH, the CH, the J sound, the R and the those are the sounds that come in last in normal development. And all of this, if the muscles are developing typically, will be developed by about 36 months of age. So when we're working with babies, we're trying to keep them on track, working on lip closure and then lip protrusion, which is rounding, and then lower lip retraction and tension, pulling our lip in. We're working on all of those skills as the baby grows up. And then we're watching their feeding skills. Are they bottle feeding and breastfeeding normally? When we introduce a spoon and cup, do they do that normally? And straw drinking, and then eventually chewing. And then we're watching those sounds as they come in, and we're making sure that those sounds are coming in appropriately as those muscles are developing. When we start with kids and adults who are older, we're looking at this same pattern. So I might work with a 15-year-old who has really poor motor control, and I might be working on opening the lips just like I would be with that 2-month-old baby, because that's the skill that they don't even have that skill yet. And I can't work on those later skills until those early skills have developed, because the early skills help us develop the later ones. Okay, next slide. All right, so this is another one that shows that same thing. We have lip movements developing, but we also have tongue movements developing. And so again, those come in a sequence, and as the baby grows up, they start to develop more and more skills. What we see often with many people with SMA and all types of SMA is difficulty with number 3, which is where the tongue needs to retract and what we call lateralize. So the tongue is going to the side to side, and that helps us with chewing. This one can often be one that maybe is there but gets really tired very quickly as they're chewing, and so they tend to often eat smaller meals and maybe graze throughout the day because those muscles can fatigue. Okay, and then on the right we see all of those sounds that are developing as well. Next slide. Okay, another oral placement goal. So we've got some sensory goals, we've got motor-based goals happening. Abdominal grading is another one, and this is where we how we speak and how we put a lot of sounds together. So we need abdominal grading or tension to control airflow to be able to speak in longer sentences. And so many times with our clients with SMA who are affected in their body, we sometimes see that abdominal grading is difficult for them. So they may speak in a lower volume. They may run out of air towards the end of a sentence. Some may speak in shorter sentences so that they can be intelligible and have enough air to say what they're going to say. So we work on abdominal grading. We work on trying to get those muscles to be active, and those are tricky muscles to work on. And I'll give you some examples in just a minute of how we do that. Next slide. Okay, so this one shows just a little bit about that airflow. So when we breathe, if you look at the graphic at the top, we take a breath in, we take a breath out, we take a breath in, we take a breath out, and it's automatic. And we know with clients with SMA, even that breathing pattern can be affected, where that what's supposed to be very automatic and not even thought about becomes something that's thought about all the time. The graphic at the bottom is how we use abdominal grading. So we use that air that we breathe in, but we slowly let that air out, and that's what allows us to say lots of words in one sentence. And then we take a breath and we speak again. So that's what we're working on when we talk about abdominal grading, controlling that air. And so if we're working with somebody who has less air to work with, we already know that that's going to be impacted and sometimes can be difficult to work with. Next slide. I see a couple of questions about working on asking about jaw. I'm going to show you some exercises in just a minute, Alyssa, that might help you with that. Number 4, avoid fixing. Fixing is an abnormal posture used to compensate for reduced stability, which inhibits mobility. So this is where we use too much tension in a muscle, and it's often seen in the jaw with our clients with SMA, where there is tightening here to get everything else to move here. Because if we relax, it's really hard for some of our clients with SMA to get that movement. I see this in my cousin's daughter all the time, and she talks about her jaw hurting throughout the day sometimes. And I feel like some days when she's got more energy, she probably is doing less of that fixing. And then on days where her energy might be a little lower, she's having to work harder at everything. She's often probably having to also work hard on her speech as well. You also think about your jaw at rest is up against gravity. So if gravity wants to bring your jaw down all the time, but you know that's not the right position for your mouth innately, you're going to use a little more tension to try and hold everything together. And that can inhibit the ability to move the jaw smoothly during eating and speech. So if you watch yourself speak, if you don't feel like your mouth moves very much and you're smiling a lot when you speak, or you're noticing that in your child, that may be some of that fixing. And really and truly, the only way to know what is by evaluating each area. So when we do OPT, we evaluate the jaw and what did those jaw muscles do by themselves, and then we evaluate the lips, and then we evaluate the tongue, and then we look at how it all works together. Next slide. Another goal, to improve feeding skills and nutritional intake. So we know that some clients may have difficulty with eating. We might see fatigue where they don't eat enough. We might see aspiration where they have poor swallowing, where food and liquid might be entering the airway. And then some have limited diets, avoiding textured foods, sometimes because of sensory reasons, and then sometimes because of motor reasons, where the more texture or the tougher the food is, the harder it is to chew up, and so they tend to avoid some of those foods. Next slide. So one of the things that we always start with is stability in the body, because that allows for maximum mobility in the mouth and good movement. When the body is in an abnormal position, even if you just push your head back and try and say, hi, my name is Renee Roy Hill, you can feel that everything is pulling and stretching in an unnatural position, where if you're in what we call a stable seating posture, where your head is at 90 degrees and your body is at 90 degrees and your hips are at 90 degrees, that allows for more flow of movement. Next slide. So we know with our clients with SMA, a lot is done with seating. A lot of times, we're trying to make the client as comfortable as possible, but we also want to consider, is that seating facilitating a good posture for that particular client? So our clients that are sitting up, we want them sitting on their hips as much as they can. And then for our young ones, having good stable posture, especially if we're going to do feeding or motor work, we might work in lying position. I'm on a webinar. All right, thanks. Sorry. All right, so always something we want to consider. Next slide. I don't think he understood what I'm on a webinar means. Poor posture. So here's an example of a little guy who's not in a good postural sitting position. And if we were trying to do oral motor work with him and speaking work and swallowing work, it would be really hard for him to be able to get control of those muscles. So we're always looking at what can we do better with seating to help our particular client. Next slide. So what does a therapeutic program look like? So if we're doing a full oral motor program that's addressing all of the goals we talked about, we're going to have a program that's addressing the client's sensory needs, addressing their feeding needs, looking at their oral placement skills. So what is their jaw, lips, cheeks, tongue, abdomen, how are each one of those muscles functioning? And then we're looking at speech as well. Next slide. So we've got all kinds of ways that we can do that. And so I just wanted to put some different ones in there for you and kind of describe a little bit about what they are. Passive facial stretches. This is what we do with our young clients who can't follow directions yet. Our older clients who don't have any motor control yet, we can use facilitated stretches. And one of the programs that a lot of us use is called the Beckman Protocol, where we're working on trying to increase movement through passive activities. And so we'll often start with that type of therapy, and then as we start to see some movement, move into some more active therapy. Next slide. Kinesiotaping is another tool that we use in therapy many times, and that's where we're using tape to help give a little more tension to the muscle and a little more sensory input to help correct some of those oral postures and sometimes facilitate some muscle movements. We might do taping around the lips if we want more lip closure. In the picture here, Madison has tape along her jaw. Every time I see her, she wants me to tape her because it helps her not have to work so hard at keeping her jaw up, because it just provides a little bit of that support. So sometimes we'll use taping with an oral placement therapy program. Taping by itself doesn't do a whole lot, but taping with activity can sometimes help our clients that we work with. Next slide. Intraoral massage are things that we can do to help facilitate muscle contractions when a person can't do it on their own, kind of like what we were talking with the passive stretches. We can focus on very specific muscles. And we can start as young as an infant. And when we start with infants, we use our fingers. And as our clients get older and have teeth or need more sensory input, we can start to use some different types of tools that will help us give more sensory input. And I'll have some pictures in just a second on the next slide of some of those things. I think it's the next slide. And they're coming. So somebody had a question about working on jaw movements, and we have a lot of exercises in our oral placement program that we use using different types of tools. This is one that we typically start with, one that can be used from birth to 100, and it's using bite tubes to help facilitate chewing. And we place them on the back molars, and I'll show you a little video in just a second, and we have them work on biting. So it can work on that range of motion that we're looking for. It can work on expanding the jaw. Some clients maybe only have a very narrow range of movement, so we'll start with a narrow tool like the yellow tool you see there, and then we can go to a wider one like the red one, and so on and so forth. Lots of our jaw work goes into that chewing motion, because when you bite down, that activates your jaw muscle, and then it's part of that function that we're looking for. Your jaw moves up and down for speech, and then in your chewing as well. Next slide. So here's a little video, and you can go ahead and start it. There's no sound, we realized, but that doesn't really matter as long as you can see the movements. It looks like it's a little bit delayed here, but this little girl, she doesn't move her jaw very much. She's talking. She has been on drug therapy since she was born, and starting to and is really kind of developing some nice movements. She didn't like me doing a whole lot to her, so we gave her the chewy tube, and I'm showing her with mine what I want her to do, and she's practicing just a little bit of biting. Her tendency is to want to do things up here, but we're trying to get that to the back molars there. Next slide. So one of the things that we're often doing is a pre-feeding program, and a pre-feeding program can be done with somebody who is eating, but we're wanting to work on those muscles for feeding because maybe they're not chewing correctly or drinking from a straw correctly or whatever. We can also do this program with our non-oral feeders as well to help stimulate all of those muscles and activate those muscles in specific ways that they would be using in feeding, but they're not because they're not an oral eater. So some of the pre-feeding activities, just to kind of give you some examples, we might work on lip and cheek activation and tongue bowling to help with bottle and breastfeeding. We might work on lip closure to help with spoon feeding, lip protrusion and tongue retraction. Tongue retraction means pulling your tongue back for straw drinking, and then we can teach chewing and work on tongue lateralization that we can transfer to chewing. So if I'm working with a non-oral eater, I can think about the feeding activities that they should have done, and then I can go to this pre-feeding program and see, are those muscles working the way they're supposed to? And sometimes they are. Sometimes they're not oral, not because of an oral, a mouth issue, but maybe a swallowing issue or a breathing issue. But then often we'll see that they're maybe not activating those muscles, so then we can put this program in place so that they can get that action going that they're not getting in eating. Next slide. So here's some of the tools that we use for those and some of the ways that we facilitate those things. At the end, I had somebody was asking, are there things to kind of teach you some of these? I'll show you a couple things at the end for that. But this is just some of the different tools we might use. Next slide. So here's a little video of doing a pre-feeding program with a non-oral eater. And he also doesn't have a lot of control of those muscles. And he is now on a drug therapy as well. So our hope is with combining this drug therapy with some good sensory motor work at the same time, we're going to start to see more and more movement. So here I'm trying to work on his cheeks a little bit. And then I'll work on his lips a little bit. And this tool that I'm using here vibrates. So it takes a lot of sensory input sometimes for these kids who don't have a lot of movement, for them to feel it so that they can then maybe activate those muscles. And we're looking for any little signs of movement from him, and we're going from there. And sometimes it takes a good couple months, 3 months to even start seeing little bits of movement. So we watch closely, and we work slowly and systematically. And once we start to see a little movement in one area, we can go to another type of activity. Okay, next slide. So why is feeding so important to an oral placement therapy program? So you might be saying, I'm eating, my child eats, or I eat. What we want to know is, do you eat and swallow in a normal pattern? Because again, that normal pattern helps us develop normal function and a good oral rest posture, and good facial development. So it also helps with the prerequisites for later speech. So if we're doing spoon feeding, it can help with client being able to close their lips and pull their tongue back, and those are movements needed for speech. Straw drinking. Sometimes kids have difficulty with spoons but can learn to drink from a straw. Some of our clients that we work with maybe don't have good hand control to be able to feed themselves, but if we teach them to drink from a straw, they can have a cup on their chair with a straw, and they can get a drink whenever they want. So we want to make sure we've taught them to do straw drinking. And then solids, when we look at what types of solids do you eat? Do you prefer softer solids? is there a motor reason that you're preferring that softer solid, and can we help you develop those jaw muscles so that you can eat harder things? Next slide. So when we talk about tongue retraction, that starts at the back of the tongue, and tongue retraction is important for all kinds of things. It's how we hold our tongue inside our mouth. It's the beginning of being able to swallow correctly. It gives us our stability so that we have good stability through our oral structure for breathing. And it gives us that stability to allow all of the other tongue movements that we want to develop with the front of their tongue. So this is kind of an example of how we work in oral placement therapy. We work in hierarchies. So you see 8 straws on the slide here. Straw number 1 is very easy to drink from, and straw number 8 is harder to drink from, and it's harder because it's a lot longer than straw number 1, and everyone in between gets a little bit harder and a little bit harder and a little bit harder. So think about it like a weight training program. Straw number 1 is a 1-pound weight, and straw number 8 is a 40-pound weight, and we're trying to get to that 40 pounds because that's what we would expect a person who has typical muscle function to be able to do. And we do it in small little steps so that the muscles can change. We can work with muscles that change slowly. Next slide. All right, so if they're not an oral eater, they can't drink from a straw or they can't chew, then we use tools to help facilitate that. So one of the tools that we use, we have, or a couple of them, we have a horn blowing hierarchy and a bubble blowing hierarchy. So that tells you that they have graded steps, little by little, to move from no skill at all to normal skill. And they can work on different types of movements. So if I'm blowing on a horn like you see in these pictures, I can work on lip closure if the mouthpiece is flat. I can work on lip rounding if the mouthpiece is round. It helps work on tongue movement, tongue retraction, and then it works on jaw stability as well, all within the activity. Next slide. So here's a picture of all of the horns. So there's 12 horns in the horn hierarchy. And again, horn number 1 is really easy to blow. You barely have to close your lips. You barely have to breathe. And then horn number 12 takes a lot more abdominal grading, abdominal pressure, and lip closure to be able to blow that particular horn. So we work systematically through this hierarchy. And not all clients are going to finish a horn hierarchy, and not all clients are going to need to start with horn number 1. We're going to figure out what can they do functionally with their mouth and their abdominals, and then we work from there. And just because we don't finish doesn't mean we don't get really good function with our goals. It just means that that particular person doesn't have the muscle capacity at that point to be able to do that exercise correctly, so we wouldn't work on that one. Next slide. All right, so here's a couple more little videos. This is our friend that we saw with the chewy tube. She doesn't know how to blow. So this is called an Alex tub flute. It's very easy to blow, and you can't hear it, but you can see I'm putting it in her mouth and I'm plugging her nose to help her figure out how to get the air through her mouth. She doesn't really like me plugging her nose, so I'm talking to her about why I'm doing it, and we're just trying with whatever she'll let us do. And when I plug her nose, after a few times, she gets a little bit of a blow there. I don't know if she was really excited about the blow, but she was willing to try again and again and again. And as she can start to figure it out, we stop plugging her nose. So right now, she's working on lip closure, she's working on tongue retraction, she's working on abdominal grading, all of those things that she needs for good speech movement and good lip closure. If you look at her when the horn's not in her mouth, you can see that her jaw is a little pulled back and her lower lip is a little pulled back. So her oral motor development is already being impacted by some of that lack of oral placement and lack of movement. So we want to get that movement going for her. She finally blew the horn. She gave her mom a hug. Okay, so let's show you another one. You can go ahead and switch it. All right, so here's another little girl, and she's older. She is verbal, but she's pretty breathy in her vocalization. So she's starting on horn number 1, and we're working on getting short, quick lows with that horn. She's working again on lip closure. She's working on tongue retraction, getting those muscles to work. So it's like an exercise program for her. And then eventually, hopefully, we can start to increase the difficulty of that horn with our primary goal for her being trying to get a little more abdominal grading. Here's horn number 2. Horn number 1 was too easy. So we're going to try number 2, and she's having to work a little bit harder at it. She wasn't able to get it quite as loud. So, and we're working on trying to teach her to keep her body still. Keep my hand on her shoulder so that she's only using the muscles that we're wanting to target. When muscles are weak, we tend to see the whole body start to tighten up. Okay, next slide. Almost done, and then we can get to questions. Okay, I have one more. So here's another little girl, again, working on horn blowing, and you can see she's got all kinds of breathing issues, but she's able to get a little bit of air through her mouth and blow that horn, and she doesn't get a lot of oral motor work. She's verbal as well, but really difficult to understand, and has a lot of difficulty with breath control as well. So we can use this with her to work on giving her some opportunities to move her mouth over and over and over in different ways as well. So, you know, when we talk about an OPT program, none of them are just on a horn blowing program and that's it. We're doing horn work, we're doing straw work if they're an oral eater, we're doing bite tubes, we're doing sensory motor work. We've got a little bit of everything going to give them lots of opportunities to practice that movement. Okay, next slide. All right, so does somebody else want to take over from here and ask questions? How do we want to do this?
Yeah, so thank you so much, Renee, for that incredibly helpful and informative presentation. I know it's a lot of information, like you mentioned, to fit in 45 minutes. So I think we'll have time for just a couple of questions that have come in from attendees. So the first question we have for you, Renee, is actually specific to this individual. So they are looking for an OPT in New Jersey, and they want to find someone who understands SMA. But I think many viewing this webinar would like to know, wherever they live, how would you go about finding an OPT near them, and again, one that is familiar with SMA?
Okay, so one of the best ways to find people trained in OPT is to go to the TalkTools website and do Find a Therapist. And you'll find therapists that have different levels of training. Now, finding one that it understands SMA, that's trickier because we know it's pretty rare and we don't see a lot of them individually as therapists. But I can tell you, most good oral placement therapists, and I was the same way when I met Madison. I had no idea what SMA is, but I understand muscle development and I know how to evaluate the muscle system, and I know how to figure out where to start. And that's what I did with Madison, and that's what I've done with other clients as I've spent more time in the SMA community. So, you know, finding an OPT therapist in general is a great place to start, and then starting to ask more questions. If you find somebody on the TalkTools website and they say they're not familiar with SMA, or you find anybody who does oral motor, you can always put them in touch with me, because, you know, one of the things we always want to know when we're not familiar with the diagnosis is what are our expectations, you know, what has somebody else done? And I'm always happy to share my stories and my information with them. I do a lot of consulting with therapists and their clients all over the world, and so that's also another idea. The person that was asking about New Jersey, there's a great therapist, and I'm going to give you my SMA, my email address at the end of this slideshow. You can contact me. But one of our lecturers is in New Jersey, and she's really good, and she has some connections with SMA, but we're really good friends and we can talk it out. So if you'll email me, I can get you in touch with her.
Perfect. Thank you, Renee. So the next question we would like to ask is how to improve swallowing, specifically after this person receives Zolgensma treatment, and what can be done to decrease the frequency of suctioning?
Okay, so swallowing is a big question because swallowing takes it involves so many different things. So you really have to be evaluated on where you're at after your treatment, and then what can we do. There are a lot of things we can do, even if they're not swallowing yet, to get that whole function going. It's just a matter of figuring out where they are and which muscles. Is it just an oral motor issue? And it is for some. Is there pharyngeal involvement, which requires a different type of test to find out what's happening there? So that's not one I can answer in 2 minutes. But again, if this person wants to email me, we can try and see if we can hook you up with some people to help with that. Any kind of oral motor work we're doing, we are always doing in the hopes that we can decrease suctioning because that particular person is starting to manage their secretions a little bit more. So, sometimes we don't know what our goals are at all when we start. We're just starting to see what happens. And many times the suctioning may be the first thing we notice is we're having to suction a little bit less because they have better sensory awareness, better motor function.
Perfect. Thanks so much, Renee. So I think this is just going to be the last one. Do you have any printouts or resources of things that we can work on with our children at home without having an OPT in place?
There are some things. I don't have specific printouts, but there are 2 books that I'll show you. Let me grab them off my shelf real quick. That are exercise books. Our whole program is based on this book, Oral Placement Therapy for Speech, Clarity, and Feeding. You can get this through the Talk Tools website. Sarah Rosenfeld Johnson, that developed this program, wrote this book, and it's not a literature, it's not a book that you just read. It's how to do each one of these particular activities. Figuring out where to start is always the hardest the hardest part. But if you're a therapist and you're wanting to have some extra things because you know of motor activities that you're wanting to facilitate, that might be helpful. Or even as a parent, I know I want to work on abdominal grading, so you can go in that book and you can go under abdominal grading and see what all is there. The other one that we do is is like a how-to book, is this one, A Sensory Motor Approach to Feeding. This has that pre-feeding program in it. So if you have a client who has very little to no movement, isn't managing their secretions, this is where we would start. They won't be able to do the things in that OPT manual. You have to be able to actively move your jaw, actively move your lips to be able to do these. These are more facilitated. So that might be helpful as well. And it describes each exercise. It gives you visuals, it tells you different types of tools that you can use to facilitate it, so it might be helpful as well. And there are webinars and courses on the Talk Tools website that teach some of that stuff as well, if that's where you're interested.
Great. Thank you again, Renee, for your time and for your presentation today. I think that's all the questions we'll be able to get to today.
Okay.
Thank you to everyone who participated and listened in on today's webinar. You will be receiving a follow-up email with a survey link, and we would greatly appreciate any feedback. We are again thankful for the support of our sponsors for making this virtual SMA conference possible. And if you have any additional questions after this webinar, whether for Renee or just in general, please reach out to conference@curesma.org. Have a great day, and be sure to check out Cure SMA's conference webpage for all of the upcoming virtual SMA conference educational and networking opportunities. Thanks again, everyone.
Bye.